hopefully everything is showing up and recording properly for our abnormal psychology class, our next to the last class. So, if I were to give you your test today and you didn't have your book available to you, could you tell me the differences between the different clusters of personality disorders? Is that something you understand? Maybe, maybe not. I don't think anybody's on the phone with me.
Can we go over those?
Sure. Oh, somebody's on the phone with me. Crap. Who is this?
Yeah. Amanda Kyler.
Hello, Amanda.
Hello.
Yes, we can talk about that. We can talk about anything you like. All right, well, why don't I hit the personality disorders, and I'll give you some commentary about those types of things. And right to refuse treatment. Betsy wants to talk about that. I was going to talk about that stuff mostly next week since it'll be our last class, but I can jump in and talk about anything, anytime if you are interested. So let me bring up just a few notes for reference so you can see them. If you have other questions, type them on in. I wait for my little slides to show up here. All right, so hopefully you can see my personality disorder notes. Can somebody just confirm that they can see those? There we go. Thank you, Betsy. Excellent. Okay, so personality disorders. Personality disorders are a little different than the other classes of psychological problems. The big differentiating factor is that with personality disorders, we really are referencing a problem of dimension. And so we can see here that the concept of categorical versus dimensional view of psychopathology is still an ongoing debate. How should we look at psychological problems? Should we look at psychological problems using a strict medical model where you either have the symptoms to get the diagnosis or not? Or should we look at personality disorders along the lines of a dimensional view? So if we were talking about it in medical terms, we might say I wouldn't say a diagnosis of pregnancy, but we'll just use that for an example. That's a categorical problem. You can check a box, yes or no. There's no in between. You are either pregnant or you are not pregnant. However, how far along you are in the gestational period, that's a matter of dimension. The developing baby will be so many months old or so many weeks of gestational age. Weight, let's say that you are, obese, right? You are going to get the check the box in a categorical manner as to whether or not you meet the criteria, which is a mathematical criteria for obesity. But when it comes to being overweight, how overweight are you? How obese are you? And a lot of times we'll come up with labels to indicate how severe a medical problem is, but those are categories applied to a dimensional variable, which is a little bit confusing, but it's really the best we can do. So what's the difference between normal weight, above average weight, obese, morbid obesity. Those are labels that we decide that we're going to assign once the dimension reaches a certain portion. But it's still talking about the same exact thing. With every other disorder, we have specifiers. So for example, if you have a diagnosis of major depression, you will get that with a label of mild, moderate, severe, severe with psychotic features. But we're really just talking about depression. So with personality disorders, this becomes really important because it really goes beyond just the symptoms themselves to make the diagnosis. The question of how depressed are you only gets asked after you meet the specific diagnostic criteria. There's no similar concept of how borderline are you in the case of borderline personality disorder. We start from the assumption that these are dimensional variables, and as much as we try to categorize them, it's really very difficult to do. So you have to think in terms of amounts and the extent to which these individuals vary from the normal personality. Now, of course, when we talk about normal, we're talking about things like the Big Five, where we go back to our definition of personality, which is enduring and relatively stable predispositions. Well, with a personality disorder, we take those enduring and relatively stable predispositions and we add the dimensions of inflexibility and maladaptiveness. And here we see some of our old definitions for what is abnormal. Does it cause impairment? Does it cause some sort of distress? If it is, then we might give the criteria or give the diagnosis of a personality disorder. This is one of the trickiest groups of disorders to think about and resist the temptation to diagnose for you as a student of psychology as opposed to a clinician. We really are talking about rather severe deviations from normal here. And so we like to use terms like psychopath or narcissist, things like that. Oops, something happened here. Hold on a second. There we go. Psychopath or narcissist, but we have to be very careful about talking about the diagnosis of a personality disorder versus an unfavorable personality trait. So you might use the term narcissist to describe, let's just say, your ex as somebody who thinks particularly highly of themselves and looks down on other people. If it gets to the point where it is an enduring and relatively stable predisposition, meaning it happens in other relationships, not just with you, and that narcissism is so inflexible that it gets in the way of adapting, it causes distress in the person's life. While the narcissist may not be upset about his or her own narcissism, they may have a lot of distress over the problems that their narcissism causes. Or impairment. They may not be able to hold a job because nobody can stand working with them. If the personality problem rises to that level, then we consider diagnosing a personality disorder. In the DSM prior version, DSM-4, when we used the 5-axis system, we gave personality disorders their own axis. For the most part, it was their own axis, to indicate these were somehow different qualitatively than the axis 1 disorders like anxiety and depression. They were thrown on axis 2 basically to highlight the fact that these don't go away. They're very chronic problems. So that's how we have to look at personality disorders as different from other types of disorders. Like the other disorders, we cluster them into groups. Now, in the case of personality disorders, when we talked about anxiety disorders, for example, there were several different disorders within the category of anxiety. Here we have personality disorders, and we break it down even further before getting to the individual diagnoses. So here we would say there are 3 different clusters of personality disorders, ones that share similar characteristics. So they're all personality disorders, but only some will be the odd or the eccentric cluster, or the dramatic emotional cluster, or the fearful anxious cluster. The one that tends to get the most attention is cluster B. Cluster B is the cluster that includes things like borderline personality disorder, antisocial personality disorder, things that cause a great deal of distress to the person and more specifically to other people. So as is typically the case, tends to run a chronic course. As is the case typically when we're talking about personality. We suggest that these begin in childhood. We think that's probably where the origins of personality lie. And these run a very chronic course. Again, if you buy the idea that your personality is stable enough so that we can make reasonable statements about and predictions about your behavior, then personality disorders are going to be as stable as that. Very difficult to treat, very resistant to change. A couple of other issues. We have to consider the problem of gender distribution and bias in personality disorders. We don't have that much of a problem with other disorder categories. But here with personality disorders, clinicians and people in the position of having to diagnose are much more likely to have a biased approach to the diagnosis of these disorders. What do you think it is that gets in the way of an otherwise solid clinician really making some judgments about people with personality disorders that could be biased? Why do we have a hard time being as objective when it comes to personality disorders? Any ideas? I'll give you a hint. Most of the problems that we see in individuals with personality disorders has to do with the fact that they can't maintain healthy interpersonal relationships. So any idea why we might have a bit of a bias problem or lack of objectivity problem? Nobody wants to take a stab at this, huh? Well, I'll tell you the answer. The answer is that as personality disorders, things that get in the way of normal interpersonal relationships, if you've known anybody with very inflexible, maladaptive personality patterns, you know that they're difficult to get along with, and you also know that they will often trigger an unpleasant reaction in people. If these things weren't maladaptive, they wouldn't be personality disorders. So we can assume that anytime you try to initiate an interpersonal relationship with one of these individuals, it's going to be quite difficult. It's going to affect you as an individual. So the clinician has to take great care not to let themselves be interpersonally affected by the individual suffering with a personality disorder, because it can lead to a lot of missteps and bias. So with respect to gender, one of the things that we know is that most of the diagnostic criteria were developed by men, and to that extent, there may be some gender bias in the actual diagnosis itself. Some of these disorders, like, say, histrionic personality disorder, are much more reflective of stereotypical views of females. Antisocial personality disorder is far more reflective of stereotypical views of males. And so we do see some gender bias language in the diagnostic criteria for these disorders. Similarly, we can expect, for reasons I just explained, some bias in the assessment of these disorders. And again, the assessment process, you remember from Chapter 3, most typically occurs via an interview. So if I'm interacting with somebody who has trouble interacting with people in a fruitful manner, we can expect that it's going to impact my ability to objectively judge an individual's symptoms. So as far as treatment for these disorders, treatment outcomes are pretty poor. There are a very few notable exceptions, but generally speaking, personality disorders are very difficult to treat, and we don't really get rid of them, but we don't really cure any psychological problem. But here, if we're trying to help an individual cope with the fact that they have this particular disorder or a particular personality disorder, it's going to require quite a bit of work on the part of the interviewer or the intervening clinician to form a relationship with the person and get them to the point where they can acknowledge that they have these issues, and then acknowledge that probably the best course of action is to learn how to live with these issues and interact in relationships in such a manner so that their personality disorders don't really get in the way. So those are that's kind of a high-level summary of the personality disorders. It probably would be good for me to just differentiate between them quickly. But if you have any questions, just pop them into the chat box. I'm happy to stop what I'm talking about and answer that question. So antisocial personality disorder, we'll start with cluster B, and I start with cluster B because it's the most dramatic. One of the things that's important with antisocial personality disorder is that you be able to discriminate psychopathy from antisocial personality disorder. This is one of those areas where we've had two, what is the word I'm looking for? Our use of the language has been too loose and nonspecific. So we have psychopathy, we have antisocial personality disorder. You may have also heard the term psychopath or sociopath. We tend to use all of these somewhat interchangeably. The key here is to understand that psychopathy is the personality style that has all of these features here, or a number of these features here. Lack of compliance with social norms, violating the rights of others, patterns of irresponsibility and impulsive behavior, and their lack of a conscience and empathy and remorse makes them quite deceitful, or I shouldn't say makes them deceitful, but it facilitates deceitful behavior. So the person with a high level of psychopathy might evidence a whole lot of those features. If the psychopathy reaches the level, again, here's the dimensional issue, if the psychopathy reaches the level where the individual's functioning is compromised, or they're dangerous to themselves or someone else, we might label that individual an antisocial personality disorder case. So psychopathy is this really maladaptive trait, evidenced by those items there. Antisocial personality disorder is the actual disorder, where there needs to be impairment of functioning. This is an important distinction because there's a lot of people who have a high degree of psychopathy, but they may reach the criteria for antisocial personality disorder, but honestly their functioning is not bad enough that it ever gets them into treatment. And so they never get the diagnostic label, if it even applied in the first place. So an individual who engages in all of these behaviors that, generally speaking, don't treat other people well, then you run into the problem of what do we do with them when they don't break any laws? Sorry, I had to put myself on mute there for a minute. I had a phone in my room going off. It wasn't my phone, it was my wife's phone. So, back in business. This is something that's really confusing for people with psychopathy, and there's a tendency to label too many people with antisocial personality disorder. That's the problem. because when you do that, you miss out on a lot of potentially very dangerous persons. Most of the people who will take advantage of you in relationships, whether they be personal or professional relationships, most likely have a high degree of psychopathy. They probably don't have an antisocial personality disorder. So just be aware that people can have those characteristics and not have the functional deficits. In terms of what causes this, I use the term cause loosely, but generally we look to early history. The big problem seems to be families with very inconsistent parental discipline and support. The key there being inconsistent. People don't make the connection between behavior and consequences when the discipline is inconsistent. Now, we don't want to blame the parents. The reality is that these individuals, probably because of some neurobiological issues, have quite a few parenting challenges that they present. There's lots of different ways of looking at this. Probably the best researched explanation is the fearlessness hypothesis, that these individuals fail to respond to danger cues. And one of the reasons why they fail to respond to cues in the environment that could signal danger is because they have an abnormally low level of cortical arousal, cortical simply meaning the cortex. So these people don't get excited, and they don't experience fear with the physiological arousal that most of us use to experience fear. And if you don't have that strong fear reaction, then you can engage in a lot of behaviors that would typically trigger anxiety in most people, but don't trigger anxiety in these individuals. This is why we can usually pick up people on a lie detection task, not a polygraph, but on a more sophisticated ones of facial expression and physiological arousal. But it's very difficult to pick up the person with an antisocial personality disorder or just a high degree of psychopathy. They just don't experience emotion like we do. Often incarceration is the only option for these individuals if they are criminals. And again, don't think that all of these individuals are criminals. But there, not surprisingly, is a higher percentage of people with antisocial personality disorder in the prison population. If you consider what the term anti actually means, we often in our culture will use the term antisocial when we mean somebody who is just avoiding social situations. That's not antisocial. Anti means against. And these are individuals who simply do not honor typical social norms and codes for behavior. This makes it very difficult to engage them in a therapy relationship because they're just not going to care. And they can be very deceptive and charming. So I've seen lots of really good therapists get completely snowed by somebody with an antisocial personality disorder. So again, I want to move kind of quickly through these. Are there any questions about antisocial personality disorder that you want me to elaborate on? Or any of the other disorders? I'll hit the big ones, at least the ones that I think are the big ones. Histrionic. These are individuals who, again, this is called the dramatic, erratic, or dangerous cluster. Individuals with histrionic personality disorder, overly diagnosed in females, like antisocial is overly diagnosed in males. They tend to be very sensational, sexually provocative, often speak in very vague terms that there's real no depth to these individuals. They seem to operate on the premise that, my identity is best found in being the center of attention. So having a conversation, not a whole lot there. I don't really know about the etiology in terms of treatment. Typically doesn't work. Now, part of the issue here is that we just don't have a lot of treatment research on histrionic personality disorder. But these would be people who are overly dramatic. Interestingly, this does overlap with individuals who would be having a hypomanic episode. It's not uncommon for those individuals to be very dramatic in their presentation, as you can imagine, and mistaken for histrionic personality disorder. The other big cluster B disorder is borderline personality disorder. And this is the one that really scares a lot of people. They are chronically suicidal. Not always, but the leading researcher for borderline personality disorder, who's created the treatment that works the best, a psychologist named Marsha Linehan, she started her research in how to help women with borderline personality disorder because she was a suicide researcher. And she kept noticing a certain pattern in individuals that have chronic suicidal thinking. The pattern that she noticed was borderline personality disorder. So she got very curious about this and did a lot to determine kind of the core features of the problem, and then also a treatment approach that does seem to help. So unstable moods and relationships, these people are often referred to as moody. They'll complain about having mood swings. Again, you need to listen carefully to make sure that this is not a manic episode, but understand that you don't want to overdiagnose a manic episode or hypomania. Here the problem is mood instability. It's not a labile mood. It's not a mood that is going to, you're going to push around their feelings in the moment, and you're going to see a lot more rapid shifting between positive and negative mood states, perhaps in the course of a day, as opposed to bipolar disorder, where you might not see a manic episode for months or years at a time. At their core, they have a very poor self-image, and by poor self-image, I mean they're not really able to define who they are. They don't show the shallowness and lack of depth that you see with histrionic personality disorder, but when you ask them to describe who they are, they really struggle. And as you can imagine, somebody who really struggles to define who they are will have a hard time defining who they ought to be in a relationship. Tremendous fear of abandonment with these people. Tremendous. Sometimes we'll go to great lengths in relationships to avoid being abandoned or what they perceive to be an abandonment. Often get into very intense, highly sexualized relationships where they fall in love very quickly and start making many future plans, because once they get connected to a person, they tend to define themselves by that relationship, given that their self-image is quite poor. And then they inevitably spook people by being overly loving, by being overly attached, and then, of course, fearing the abandonment. Fully expecting in some, I've known cases where women would have, the proverbial one-night stand, and then be very distraught that the person doesn't call back or didn't really intend to marry her. Well, that's really not the way that it works. So in relationships, they're just chaotic and dramatic. Marsha Linehan considers this to be primarily a problem of affect regulation. These individuals, emotion regulation. They don't regulate their emotions well at all. At all. And so they end up doing a fair amount of self-mutilation, which can sometimes escalate into suicidal gestures. The self-mutilation, cutting specifically, is a focusing mechanism. When you're feeling out of control and you don't know where your feelings are going to go, people will often cut because that cutting will capture your attention. And if your attention is just focused on that one thing, like we would have in a meditation training, then you don't tend to worry about the 17 other things that have been flying through your head. Causes, Marsha Linehan, again, she argues that the primary sort of foundational problem in these individuals is that they have a high degree of emotional reactivity. They don't regulate their emotions well, and they're born into a family that provides what she references as an unwelcoming or an invalidating environment. So these are individuals who have a hard time regulating their emotions. They make other people feel uncomfortable. They're constantly being told, stop, don't do that, stop, don't do that, stop, don't do that. So they never really get a chance to develop an identity because they're too busy not being a certain individual. So when you take a highly volatile, emotionally volatile individual and you place them in an environment that doesn't tolerate that particularly well, and to be honest, most families don't tolerate that particularly well, then that might set a person up for a borderline personality disorder. Treatment options, antidepressant medications do seem to help for some people. Why they help, we don't know. And this particular type of therapy called dialectical behavior therapy, which is discussed in your book. But dialectical behavior therapy, at its core, is behavior therapy that attempts to train into you or help you practice and develop entirely new repertoires of behavior instead of trying to stop unwanted behaviors like the invalidating environment did. So for example, an individual in dialectical behavior therapy who cuts for relief when they're under some sort of distress. Dialectical behavior therapy, of course, would not want you cutting, but it's not going to make cutting the focus of treatment. What they're really going to focus on is how do I find other ways to soothe myself when I'm upset. Also, a large part of that treatment is acceptance. Some things we just need to accept, some things we need to change, and some things we just need to move on from. Acceptance is important because a lot of this emotional dysregulation that these individuals will feel isn't going away anytime soon. Questions about borderline personality disorder or cutting or chronic suicidal thinking. Some of you must be in the position where you have met people like this and been worried about people like this.
Dr. Henley, my mother had multiple personality disorder, and you said it's not curable?
Well, yes and no. We're talking about two different things. Remember, this is borderline personality disorder. Multiple personality disorder, and one of the reasons why they changed the name to dissociative identity disorder is because people frequently put multiple personality disorder into the category of personality disorders, which would make sense since they have an overlapping name. But the multiple personality disorder or dissociative identity disorder is not one of the personality disorders. And the treatment outcomes for people with dissociative identity disorder is not good. It's particularly poor when you try to fix the element of the disorder, the core element of the disorder, which is switching from a host personality to an alter personality. That process doesn't seem to produce any good results, and there are very few studies that document anything really helps. What seems to be most useful for these individuals is to treat post-traumatic stress disorder, because in the vast majority of cases of multiple personality or dissociative identity, pick your title, we see people with quite elaborate abuse histories. And so generally we think that the best way to treat multiple personality disorder, assuming it's an accurate diagnosis, is to treat the trauma, not try to treat the multiple personalities. Does that make sense?
Yes, it does.
Good. Good. So yeah, that is a confusing thing. I mean, a lot of people will assume that multiple personality disorder is, a disordered personality, but that's not the case at all. Not the case at all. In fact, often people with a dissociative identity disorder, they are quite flexible. They do have good social relationships, but their impairment is so severe due to this pattern of dissociative episodes where they just break with normal reality.
Does the outcome of treatment and success of treatment of even just the PTSD prove to be more successful if it's caught early on?
That's really not an answerable question. The reality is we just don't have good treatment outcome studies for people with dissociative identity disorder. So to know, you really wouldn't be able to answer the question, does treatment have a greater effect if it's caught early on? Of course, that tends to be the case with any psychological problem. The earlier you catch it, and the earlier you catch it, hopefully the person hasn't adjusted to it and organized their life around the symptoms. So generally speaking, yes, the earlier you catch it, the better. But just because you don't doesn't necessarily mean that it's not going to be well treated. Does that make sense?
Yes, sir, it does.
Okay, good. And this is one of the things that's challenging about these types of disorders. Everything that we have to treat the personality disorders, and in this case, dissociative identity disorder, generally speaking, is not particularly effective. However, these individuals are suffering, and they deserve treatment. And one of the reasons these disorders were always placed on a separate axis is so that a clinician such as myself, when we're treating the problem that the patient comes in with, like, say, depression, I'm aware of the fact that when I'm treating this individual for depression and I'm using research-based treatments, that this is going to be helpful for most of the people most of the time. But if the individual comes in with depression, but they also have a personality disorder, I have to keep in mind that the normal way in which I would administer treatment to somebody for depression has to be adjusted to accommodate the personality disorder. And that's why it was always coded on a separate axis, to make sure that the therapist knows, okay, you might be treating depression, but you have to remember you're doing it within the context of borderline or avoidant or some other type of personality disorder. It's a good questions. Yeah, I think Julie is right. Generally speaking, if the disorder is caught early enough and it hasn't caused a lot of chaos in the person's life, it's easier to treat. So, for example, particularly women with borderline personality disorder, women with histrionic personality disorder, these are women who are prime candidates for abuse at the hands of people who are unscrupulous. So, for the person who, we could say the individual who might have a high degree of psychopathy, they can really wreak havoc in the life of one of these individuals. So, the longer you go through life and suffering the consequences of having the problem, the more difficult it is to treat. So it's not at all uncommon to see somebody come in with borderline personality disorder who has a history of sexual trauma, who has a history of physical abuse, who has a history of, an inability to keep a job, and on and on and on, which, gives you fantastic self-esteem. And if every relationship you've had ends up, a disaster, I'm speaking, a little colloquially, but if, generally speaking, you haven't had good relationship outcomes, why would you expect a therapy relationship to have a good outcome? Often you don't. And then the more bad experiences you have, the less you tend to expect things will get better. Thinking back to the learned helplessness view of depression. So, a couple of others. Narcissistic personality disorder, as I had mentioned, easily confused with antisocial personality disorder, easily confused with histrionic personality disorder. Notice that they all are in the same cluster, so we would expect them to share some similarities. But whereas the histrionic requires a great deal of attention because he or she doesn't know what to do if she's not the center of attention. And unlike the person who's antisocial, who does things to people because he just doesn't care about people, the individual with narcissistic personality disorder will do what he or she does not because they need the attention and not because they don't care about people, because they have an overly inflated sense of self-importance. They really do think that there's something special. So they're preoccupied with receiving attention, not because the attention feels good, but because they constantly need their specialness validated by other people. They'll often be very insensitive and incompassionate for other people, especially those less fortunate, because what do you have to offer the king? If I'm narcissistic and I want to make sure that I get my specialness validated, it's easier to do that if I'm going to important people rather than little peons. So you can imagine that somebody who's narcissistic will be very, very sensitive to criticism, very angry in the face of criticism, because they don't want their identity diminished. Again, treatment, we don't really have treatment that works. Might be better to work on the coexisting depression. Cluster A is the real odd eccentric disorders. And here we have paranoid personality disorder. And the key concept here is suspiciousness. Suspiciousness that is pervasive and unjustified. So, individuals who are acting very suspicious because they've just been the victim of a crime, we wouldn't diagnose them as paranoid. If the individual has a pattern of being distrustful and being in situations where perhaps being distrustful was functional, well, we wouldn't want to diagnose those either. Ethnic minority groups who have been subjected to discrimination and other forms of persecution were very, very careful before assigning this diagnosis to those individuals. So there's lots of reasons why one might look paranoid. And remember, paranoid is not socially anxious or worrisome. Paranoid is where you're convinced that there's an organized effort to undermine you. We don't really know why this occurs. Maybe because you see so many people who have been treated poorly showing signs of this. Perhaps that says something about the origin. We don't know. And we just don't really have a whole lot of treatment outcome research to show that anything works. The schizoid personality disorder, this is where a person has a real pervasive pattern of detachment. They're very much the loner. They have very limited range of emotions. The isolation preference looks somewhat like autism. It also looks somewhat like the negative symptoms of schizophrenia, where the person lacks emotional expressiveness. These are people who would just prefer not to be with other people. The dependent personality disorder craves social connection. Even the person with social anxiety craves social connection. They just wish it didn't make them so anxious. The person who's schizoid really doesn't want anything to do with social interaction. So if they have jobs, you probably will find them working perhaps late night jobs, stocking shelves someplace where they can just put on their headphones and put on their sunglasses and dip into their own world. You definitely need a job where socialization is, not a big deal. Schizotypal, I'm going kind of fast here because I know it's late. These individuals look a lot like high-functioning schizophrenics. They're odd, and there's no missing them. It's not that they're a little, eccentric. They're really odd in terms of how they dress. They're often highly suspicious, like the paranoid. Not quite as bad, but often. They tend to have magical thinking. Ideas of reference being when you think something is being said, perhaps even on the television, and thinking it must be a special message to you. That's what idea of reference means. Other things are referring to me. We don't know what the cause is. We think it's somewhat like schizophrenia. These individuals almost never come into treatment unless it's community mental health. We just don't know enough about them at all in order to make any judgments about what might be useful for treatment. The person with avoidant personality disorder, by contrast, there's good data to suggest that if you treat these individuals like you would treat somebody with social phobia, they can show some pretty good improvement. Unlike the schizoid, they are desperate for connection, desperate. But they're so sensitive to other people's opinions and so fearful that they're going to get rejected, they end up avoiding most interpersonal relationships. There's a very severe and pathological fear of rejection. Early rejection, particularly from one's parents, parenting that makes them feel like they can't measure up. These may be causes. It's hard to say. The only way really to know the causes of personality disorders are to track people over their entire childhood, and that's just not feasible. The dependent personality disorder, again, very concerned about rejection, but instead of avoiding people because you might get rejected, people with dependent personality disorder are more likely to go overboard to try to prevent the rejection. So they can be very clingy and submissive. They have the similar fear of abandonment. But they really don't feel like they can make decisions about their life without the input from other people. And then lastly, obsessive-compulsive personality disorder. So the big difference here between obsessive-compulsive personality disorder and obsessive-compulsive disorder is that the anxiety disorder, obsessive-compulsive disorder, you have individuals who are engaged in ritualistic behaviors who realize, at least occasionally, that their behavior doesn't make any sense and are distressed by it. With obsessive-compulsive personality disorder, people are not distressed by their obsessive-compulsive characteristics. They very much are committed to doing things the right way. They tend to be very perfectionistic, orderly. If I've heard it once, I've heard it 1,000 times. There's a place for everything, and everything has its place. And you don't want to violate that. So they actually are quite rare with respect to showing obsessions and compulsions. Again, treating the fear, the anxiety associated with the disorder is more important than actually treating the symptoms themselves. So, it's 9:30. We've been going for an hour solid. I think I've covered every one of the personality disorders. I will try to address Betsy's question very quickly. And I can tell you how it works in Virginia real quick, and then I can elaborate at another time. So, because you're interested, and it is something to be thinking about as you read Chapter 14, you do have the right to refuse treatment to a point in the Commonwealth of Virginia. To a point. So individuals always have the right to refuse treatment unless they are committed to a psychiatric hospital and the psychiatric hospital believes that there's no other way to help this individual than to give the individual treatment. Usually this is in the form of medication. Often it's in the form of a shot. But just simply being admitted to a psychiatric hospital doesn't relieve you of your right to refuse treatment. You can be committed to a psychiatric hospital, and then the hospital has to go one step further and ask that a judge issue an objection, and the authorization to administer medicine over objection. They call it a meds over objection in shorthand. So should you have the right to just refuse treatment flat out? To a degree. Usually the only individuals who are going to be subjected to medication over their objection are people who really can't consent to treatment anyway. They're so psychologically out of it. They may not know who they are, or they may know who they are, but they don't have the ability to express a treatment preference. They can't talk about the pros and the cons of, say, refusing their medicine. They just don't demonstrate they're competent to make a good decision. And so the state will come in using the legal philosophy of parens patriae, which means state as parent. The court will often make the decision that this individual is just not capable of accepting treatment, therefore they're not capable of refusing treatment, and if the doctors say that the only way to really help restore this person to sanity is to treat them over their objection with medicine, then the judge may or may not consider that. Does the individual have a legal right to appeal a court order in Virginia? Yes. So the process essentially is that if you are hospitalized against your will, initially it's on what's called a temporary detention order, which only lasts 72 hours in Virginia. If you are committed at your court hearing, so there's no appealing the temporary detention order. You're there until the 72 hours are up, and then you go to court. If you don't like the ruling of the judge, or in this case, around here we use a special justice, which is a local attorney who's sworn in as a judge just for the length of the hearing, and then their judgeship, whatever it is, goes away. So you can't appeal the temporary detention order, but you can appeal the ruling at a hearing. I've had a couple of those come up over the years. But yeah, you can always appeal. If your appeal is denied, then you'll be in the hospital for up to 30 days. If the hospital doesn't think that you can leave even after 30 days, then they'll request to go through the commitment hearing process all over again. So yes, you do have the right to appeal. I wish I could tell you that every hospital I've ever been associated with actively informs patients that they can appeal, but they can appeal. So let's say a couple of other questions. We become a revolving door. They force meds and treatment so they're released only not to take them again. Yep, that's exactly what happens. After the Virginia Tech shootings, mental health law in Virginia changed quite a bit, and there is a provision at your commitment hearing where the judge can order you to outpatient treatment. You would be required to go to treatment, and the judge says you have to go to outpatient treatment until your outpatient treatment provider releases you. However, I can tell you as the person who does these evaluations and can recommend that as one of the options, it's almost never used. People, I don't know of anybody who's ever been mandated into outpatient treatment. And the reason for that is just one of, practical matters. How do you enforce a court order that you must attend treatment? And what is the treatment provider supposed to do? Missy here doesn't show up to my therapy appointment. She hasn't shown up 3 times in a row. I know the court made her come. What am I supposed to do? Who do I call? Do I call the sheriff's department? Nobody seems to know.
I have a question. In situations like that where children are involved and they remove the children, when people don't show up to their therapy sessions, that will be reported, correct, and that'll interfere with them and the custody of their children if it was revoked temporarily or something like that?
Is your question, would that make people go to therapy more often?
If that's the term of their therapy, does it seem to be that more people comply with therapy when things are like the custody of their children are in jeopardy?
Yes. And generally that is not the most fun type of therapy to do. People are much more likely to comply with the court order when there is some punishment associated with not complying. But in the case of somebody being released from a psychiatric hospital, there is no punishment that's being applied. It's not like with substance abuse. If you don't complete your substance abuse training, then you're going to have to go to court for that DUI. It doesn't work that way. Basically we are saying you have to go to therapy for your own good. And the person may decide, nope, I'm fine just on my own. But the short answer is yes. Under situations where the court is coercing an individual to go to therapy, those people are usually going to show up, I would say. But you can't really expect a whole lot to come out of that therapy because they're not wanting to be there in the first place, which is quite sad. So Julie wants to know if the personality disorders we talked about tonight, given the fact that we don't really have good treatments for them, is that a lifelong sentence? Yes, but I wouldn't use the term sentence. So I think part of the challenge is to get people to recognize that they have one of these personality disorders. We'll just use the case of personality disorders. Get them to recognize and acknowledge that's what's going on, and then they can figure out, all right, since this is the way I am, then perhaps I can find a way to work around these symptoms, and actually have a life that I value. So lifelong, probably. Death sentence, probably not. Probably not. With a lot of these you can work around. The only one that would be really, really tough would be antisocial. Interestingly, when people are mandated to outpatient treatment, this is one of the problems with the law, there is no specific service to which they are mandated. So in the case of substance abuse, if you're remanded to substance abuse treatment, that's almost always carried out by the community mental health system, and they have a program that everybody goes through. It includes therapy, but to my knowledge, I don't think it includes medicine. But the form that gets checked at the commitment hearing simply commits an individual to outpatient treatment. It doesn't specify what type of treatment it is. So for example, I can show you, let me pause this for 1 second. I'll show you the actual document that gets used that I complete for individuals who are hospitalized. So hopefully you can see my screen again. And what you'll see is a document that I complete. And if you look at this section here in the certification, this is where basically I write in the individual's name and I indicate that I evaluated them in person. Remember that with mental health law, you can't really apply any mental health law until there is a certification or testimony from a professional that there is the existence of a mental illness. Now that might seem obvious, but mental illness means diagnosis. And while you would be like, well, of course they have a diagnosis, it wasn't that long ago when you could, wander into your local sheriff's office and say to the sheriff, you got to go pick up my wife and take her to the hospital. She's crazy. All week long, all I've heard is a whole bunch of back talk from this woman, and she's out getting my dinner on the table, and now she says she's not going to do laundry. So she's crazy. She needs to go into the hospital. We needed to do away with that, and so the law requires a diagnosed mental illness. You have to then certify whether the individual, this is important, as a result of the mental illness, are they unable to care for themselves, or are they going to be a harm to themselves, or a harm to others? All we can do is assess risk. As a result of mental illness, will suffer due to lack of capacity to protect from harm or provide for the basic human needs. Most people are capable of doing that, but these are the treatment options. Either requires involuntary inpatient treatment or involuntary outpatient treatment. Very different, right? So again, we can recommend to the judge that the judge order outpatient treatment, but who's going to put the teeth in it? Unfortunately, no one. So often, let's see, like for substance abuse, a substance abuse treatment program will involve typically in community mental health, the substance abuse treatment program will include individual therapy, group therapy, and sometimes medication, depending on the case. All right, well, ladies and gentlemen, it is 9:43. It is later than I wanted to keep you. So I will take this opportunity to just bid you good night. Next time we get together, we can talk about the mental health system a little bit more. I'll talk about anything else you want to talk about. We'll talk a little bit about psychosis. If there's anything you want to know, just let me know. Shoot me an email. And if I, don't get back to you, call me. And you can also post things on those discussion boards. People don't use them very much, I don't think, but if you decided to use them, then use them. And I'll be checking in on them. All right. Well, good night, everybody. Have a great week and hang in there. Semester's almost over, and I'll talk to you soon. Take care. Bye-bye.